I'm Dr. Lilley, and I'm a sports medicine specialist at the center, and I primarily focus on shoulder problems and knee problems. And I wanted to go over this evening the advertised lecture on meniscal problems. And without further ado, I'll get started. So, we are going to look this evening at the knee meniscus and go over how it affects your life and maybe some of the problems that you're having right now. I will look at the anatomy and possible ways of injury, along with treatment options, including physical therapy and others, and then potential repair options and treatment surgically, along with treatment in the setting of wear and tear, which is very, very common these days. And then I want to go over recovery from surgery, and then other options if meniscus surgery isn't the best option. So kind of looking at more bigger picture items. So I'm going to start with anatomy, and the meniscus anatomy is actually very interesting, at least to me. I spend a lot of time working on it, and it is one of the most important parts of the anatomy of the knee. It is a major shock absorber. It provides significant cushion to the knee, and transmits over half of the actual weight of your body that goes through the knee. It isn't just the two bones touching, not just the femur bone and the tibia bone, but it gets transferred through the meniscus by and large. And this is especially when our knee gets bent into flexion, when we actually bend our knee. So that's why it becomes relevant with sports or other recreational activities where we're not just standing and walking, where we're twisting and turning and dancing and moving all around. This is one of the reasons why the meniscus is so important. It actually stabilizes the knee during these activities. It's made in multiple layers, and this helps give it some structural integrity. And then looking at one of the most important aspects of the meniscus, and this gives a good profile view of it, that it originates from the side of the knee, both on the inside and the outside. We have two of them. So one's the inside medial meniscus, which I'll go over, and then one is the outside lateral meniscus. And they provide a nice contour to the two bones, and the two bones are covered in cartilage. As some of you may know, the cartilage is a lubricated surface, has very few cells in it, and does not have any blood flow to it. Very similarly, the meniscus doesn't have any significant blood supply going to it. And this is why meniscus problems can be such a challenge, because when there is an injury to the meniscus, it doesn't heal very well. And this slide is important because it shows where the blood is coming from. It comes from the outside, kind of the lining of the knee. And that this only transfers through part of the meniscus. And so a lot of us get tears in this region if we have a tear, and there isn't a lot of good blood supply. So I mentioned here that 20 to 30% of the meniscus on the inside has blood, even less on the outside meniscus, that lateral meniscus. The inside meniscus is a little bit smaller. It's a C-shape. Actually, I mean that it's a little bit, it doesn't take up as much of the surface area of the inside of the knee. It's actually a very large component of the inside of the knee. And it transfers quite a bit of the contact forces between the femur and the tibia. And this helps provide stability and a cushion. And then the outside meniscus is more circular, and it covers more cartilage. And that in this way, it provides a lot more of the support of the outside of the knee, that lateral side of the knee. And it is less connected to the surrounding parts of the knee, so it's less rigid and it's more freely mobile. So it can actually slide back and forth a little bit when we bend and extend our knee. And this helps it be more flexible and less prone to tears, which is good. So I talk about meniscus tearing, and tearing occurs in two main ways. One is an acute tear, is probably the way most of us think of a tear, that it's gets pinched between the two bones and can actually propagate a part of the meniscus separating. And it can occur in many different ways, in many different patterns. Everything from within a longitudinal or long tear in the meniscus, or going in from inside to out. And we have a bunch of different names for these, not really relevant to this evening's talk. But what is important to know is that some tears lend themselves to being more amenable to repair, and some don't, unfortunately. And by and large, many meniscus tears aren't able to be repaired. And a lot of this is because of that blood supply I was talking about. And I'll kind of go into more detail a little bit later. So those acute tears usually feel like a pop, or it's kind of a sudden injury. People notice swelling afterwards. They notice a sudden pain after an incident, and there's usually quite a bit of pain, difficult to walk. There can be then maybe even a little bit of a click afterwards, or some feeling. I sometimes ask patients whether they have like the feeling of something stuck inside their knee, or that it's difficult to move it around. It's not often locking, or like where your knee isn't able to bend. If it does occur, it's a very large tear, and usually a pretty urgent problem to deal with. And then one of the more common meniscus tears I deal with is these chronic or long-term tears. I call them degenerative tears. So usually wear and tear type tears. And actually the picture in the upper screen shows these tears, this type of tear rather. And this is more just kind of the meniscus getting beaten up over time. That as we use our knee and we it gets a little bit more rigid, a little less durable, and easier to break apart. And these tears, almost 100% aren't repairable. There's just not good tissue to heal to, and they don't have good blood supply, and the tissue is already unhealthy. So almost universally, we clean these out when they need to be addressed surgically. So kind of looking into how the tear patterns occur, I wanted to show kind of the rotational injury that is usually associated with a meniscus tear in the acute setting, so all of a sudden, and occurs with usually slight flexion, a lot of pivoting, rotating. So we see it on a lot of sporting injuries, a lot of slips and falls, going up and down hills and landing wrong, falls off of ladders, things like that. And I showed some of these tears just to give a general idea. These radial tears at the top, usually we clean these out, but something more like the longitudinal tear at the bottom, those are the ones that I mentioned can be very large and can flip across the knee and cause locking. Those tend to be the types of tears that we repair. And both of them can be acute, and both of them can be chronic. It's really hard to tell. We base it mostly off history and what's happened. And then I always like to include this slide because it's actually kind of interesting. We always wonder what actually causes pain inside the knee, because some things actually don't have a lot of sensation. We experience pain in the knee from the nerves that innervate the knee. And some areas, like other parts of our body, like our hands, have a lot of innervation and are a lot more sensitive. So one of my mentors, when I was going through training in San Francisco, actually had just local anesthesia in his knee just for the incisions, but actually had one of his friends and colleagues do a knee arthroscopy while he was awake. And he could actually describe what hurt and what didn't. And it's a very famous paper amongst orthopedic surgeons, because it is quite bold and noble to allow somebody to do this to you. But he mapped his own knee, and whatever is dark in the knee is very sensitive. So a lot of what causes our pain is the capsule, is the lining, the kind of soft tissue surrounding of the bones and the cartilage. There's like a fat pad. We all have a fat pad behind our kneecap tendon, and that is also very sensitive. You can see that kind of in the middle is the meniscus, and that is quite specific for pain symptoms. So if we have pain right at the joint line, right where the femur and the tibia meet, that does tend to point towards having a meniscus problem very often. Not universally, but it gives us a good idea that that might be where the trouble lies. Amongst other problems of the knee include cartilage injuries and ligament injuries, and these areas are also quite sensitive, but can be comparable to the pain in the meniscus. So usually when we have an injury to the knee, it's not so much the actual structure that's damaged, it's actually the surrounding lining that is more inflamed. And so that's why when you have an acute tear, it can be very sensitive, but then it can become kind of this nagging, irritating pain because of the surrounding inflammation. And so that's generally what causes our pain. So I'm going to take a quick stop here and look and see if we have any questions, and feel free to jump in and send any questions. I'll kind of keep moving along, and hopefully this is useful to everyone. So conservative treatment, that's usually where I start. There's the few instances where there's an acute injury, a lot of swelling associated with the knee, loss of range of motion, and this is where we kind of have to jump ahead a few steps and fix the anatomy of the knee. But a lot of times meniscus tears, they don't always need to be treated surgically, and that's important. Not every meniscus tear will continue to cause problems. Some of them cause problems from time to time. Some of them cause problems only in the beginning and then go away and are never a problem again. And then there's the others that tend to need to be addressed surgically and tend to be nagging issues. So conservative treatment, a lot of us have heard of the RICE therapy, rest, ice, compression, elevation, and then those non-steroidals, including Aleve, Advil, and then some prescription medications. Those all help decrease the inflammation inside the knee, but none of them really address the tear itself, but always a good place to start. I always get X-rays of the knee, and folks sometimes wonder, well, can you see the meniscus with an X-ray? And no, you can't usually. But X-rays give a good idea of overall alignment of the femur and the tibia. They show if there's any other associated problems, any loose fragments of bone. They also show, the most important is the joint space for evaluating cartilage and meniscus problems. And the joint space is clear, basically. It's the clear separation between the femur bone and the tibia bone. And you can see on the left-hand picture that there's relatively normal joint space between the inside and the outside of the knee. That outer lower bone, the fibula, shows the outside of the knee. And then the inside is where a lot of us get a lot of wear and tear. It's where about 60% of the body weight goes through. So it tends to wear out a little faster than the outside of the knee. And you can see on that right-hand picture, that shows arthritis of the knee, or what we call chondromalacia, loss of cartilage. And that's, some people say they have bone on bone, and that's because the cartilage is all worn out. And so there's no real joint space anymore. And people develop bone spurs as a reaction to that inflammation. It doesn't actually heal the issue, it's just a reaction. And so it's good to assess, because when folks have meniscus problems, if they also have underlying arthritis, that adds a whole different element. And if usually there's arthritis, meniscus problems kind of take a backseat to the overall picture of arthritis in the knee. So X-rays are good for that. And then I sometimes consider bracing. It depends on what the actual issue is. If people are dealing with knee instability, bracing can be very helpful. Some people like having a brace just for that feeling of support and comfort, but I don't universally recommend them. It's kind of on a case-by-case basis and to see if they're helpful, but that's definitely not required by any means. Kind of touched already on anti-inflammatories, those non-steroidal, that's those NSAIDs, non-steroidal anti-inflammatory drugs. They're helpful acutely and over the course of a week or two. They can have some long-term side effects on the stomach and the kidney, so it's important to talk to your doctor about how they can be used and just to be careful with them. Tylenol can help as well. It's another type of anti-inflammatory. These days, we've been really trying to avoid opioid use, except in very, very serious acute injuries because of the many side effects that a lot of us know about. And then one long-acting anti-inflammatory, which maybe you've heard of, is cortisone injections. And these are in very common use. And there's a lot of positives and negatives to cortisone. I get asked a lot about how useful they are and what their downside is. And I feel that cortisone can be a great option for folks who want to get back to an activity, try and rehab their knee with significantly less pain. And they take, after an injection into the knee, cortisone can take about 2 or 3 days to start, and that's because it has to actually go into the cells of the knee, whether the lining and surrounding structures, to actually turn off the inflammatory response. And it works very well to decrease the swelling, decrease the pain, and it can last for months, anywhere from 3 to 6 months. I've had folks say that they were better for a year. Hard to say, but the general rule of thumb is that they're about 3 to 4 months of effectiveness. And I never use them as an ongoing treatment for a meniscus problem. It can be good to kind of diagnose, so is this problem inside the knee, actually where the cartilage is. It can also be helpful to, like I said, help folks rehab, but it's not an answer for months and months and years. As cortisone has been shown to break down cartilage, break down connective tissue over time. 1 or 2 shots is not going to do this, though. I mentioned physical therapy. There are a lot of modalities, but by and large, physical therapy and working with a formal physical therapist can help with achieving better range of motion, achieving better strength, and learning how to stabilize your knee in a way that applies less pressure to the meniscus and cartilage and balances the knee better. And this can help decrease pain and inflammation as well. So definitely a good treatment option for conservative treatment. And then there are the second type of shots that I like to mention, and these are these knee lubrication shots. Hyaluronic acid is the name. And they serve as a way to cushion and support the cartilage in the knee, including the meniscus. And basically what these injections do, they're usually a series of 1 to 3 to 5 injections. And your doctor will provide them over the course of several weeks. And they help to actually decrease the inflammation in the knee and support the cartilage cells. It turns off inflammation and pain generators and kind of changes the environment of the knee. It can be very helpful over the course to relieve pain over the course of, say, 6 months usually. So that is also a good option. And then I mentioned that we get imaging, including X-rays, but to actually evaluate the meniscus, we really need an MRI. It's the best way to see any tears, any problems with the meniscus. And although it can't pick up every meniscus tear, it can pick up the majority. And what it does is it looks at fluid inside the knee. And fluid's usually where we have injury. And injury usually picks up the joint fluid, and it picks up the swelling in the area. And this is what the magnets, the MRI can do. It can pick up this in an image form. So it gives us a lot of information and gives us a roadmap for surgery. And this is what an MRI image looks like. And you can kind of see in the line here that going through this triangular structure, that's what a meniscus pad is in the back of the knee. And it's usually, this is just a slice through the inside of the knee, so that medial side. And that white line going through the meniscus pad is a tear. So that's what we're looking for. Normally, this would be just a big dark triangle and healthy looking, just black triangle. And you can see that this one has a line going through it. And then alternative treatments. There are many, and I get asked about them quite often, everything from stem cells to CBD. And It's hard as a physician because a lot of this is anecdotal. It's kind of word of mouth treatments. It has, and it's allowed. Some of them are allowed just because they've been shown to not be harmful, but they're not necessarily something we always want to recommend if they're not universally better than what we say placebo or sugar pill treatments. So stem cells are definitely in infancy. It's been used. They have been used. To inject in the knee. What we have found out is that many injections, everything from injecting saline or salt water to PRP injections of platelet-rich plasma. So it's when we spin down your blood and just take the plasma and the platelets portion. And that can help decrease inflammation. They all decrease inflammation, but they don't actually cause regeneration or healing. So helpful in decreasing pain, but not necessarily proven to be a cure or anything like that. CBD is very helpful for inflammation, and that's also anecdotal. It can serve as an anti-inflammatory, but beyond that, it's relatively expensive. But I've seen it in my practice to be helpful for patients who have longstanding pain symptoms and such. Glucosamine has been proven to not be helpful, that it's expensive and that people may feel relief, but a lot of that is that placebo effect, that feeling that they're doing something good for themselves, even if its actual function in the body isn't that helpful. And then cold laser therapy can be helpful in some studies as an anti-inflammatory. I have patients who definitely swear by it. And ultrasound works in a similar method. So also options, non-surgical options to decrease that inflammation in the knee. None of them have been proven to heal the meniscus or cause it to knit back together. I'd like to just touch base on what else can be causing knee pain, because it's important. Not every knee injury is a meniscus tear. So one of the most common causes of knee pain is this front of the knee pain or patellofemoral pain, and it includes patellar tendonitis, so jumper's knee. It includes overuse injury, doing too much too fast, everything from deciding to hike the Pacific Crest Trail or I'm going to run a marathon. That's where I see a lot of this front of the knee pain. It's the body hasn't been able to catch up and build up strength fast enough to help support the knee and the kneecap tracking specifically. So that kneecap has to run over the femur a lot when we're running or climbing hills, and this can be a cause of pain, not necessarily a meniscus tear. Tendonitis is very similar, and a lot of times it's friction of the tendon or too much stress on the tendon causes pain, and it can last a very, very long time. It'd be very, very problematic. IT band, iliotibial band, which is kind of that on the left hand of your screen, that blue structure, that can be very irritating and very painful. I've seen folks have a hard time walking with it. And it's an area of the body that also that does not have good blood supply, doesn't heal very well. So just because it really hurts and keeps you from walking doesn't necessarily mean it's always a meniscus tear. It can be outside of the knee, it can be a tendon, it can be a ligament as well. And then bursa, these are these loose connective tissue areas along tendons that help them to glide over bones and other firm structures like ligaments. And they can get inflamed, have a lot of nerve endings, they make fluid, they can swell, just like you can see this is a bursa on the front of the knee. We all have a prepatellar bursa, front of the knee bursa, and it could get quite swollen as well. These can be causes for knee pain. And then just jump in here and we'll go over knee arthroscopy now. This is kind of one of the main topics that I really want to talk to, because it's what we all think about with knee surgery and what we can do for a meniscus tear. And feel free to ask any questions. I'm happy to jump in there and answer them. So knee arthroscopy, I included this image. It gives this is basically what a knee arthroscopy looks like from the observer's view. I usually make 3 portals, so 3 little incisions in the front of the knee. So it's minimally invasive, and it allows us a lot of access to the knee and the ability to repair many parts of the knee. So it's a huge advancement in orthopedic surgery. It's been around for some time now, but as a great option for a lot of people. And I do like to talk about repair, although it is not the most common meniscus surgery we do. It's a very important option. And this is sewing the meniscus tear back together. And these are a few pictures of what we do. We have some nice instruments that allow us to use anchors from inside and out of the knee. So starting from the inside while we're working to repair with a stitch for that tear. And this relies on having blood flow. Any tear won't heal unless there's some blood that's providing nutrition. A lot of the meniscus that doesn't have blood gets its nutrition from the joint fluid. We all have joint fluid in our knee, and it has sugars and other nutrients floating in the knee that help support it, but that's not enough to heal a meniscus tear. So that's why not all of our tears are repairable. And I mentioned that when we do these repairs, the failure rates are somewhere in the 10 to 15% range. And so good success, but not 100% by any means. And then I mentioned there, when the meniscus actually becomes detached from the back, from its attachment points in the center of the knee, that this is a very important surgery, but also a little uncommon. That we can repair it down to the bone. So reattach kind of the origin of meniscus down to the bone. And this helps support the knee significantly because it's that, 50% shock absorber of the knee and stabilizer. So if you lose that root, you lose almost all the structural integrity of the meniscus. So we repair those whenever we have the chance, but they are hard to get them to heal. So an important option, but somewhat rare actually. And then the most common form of meniscus surgery is this debridement. We call it debridement, or the so-called clean out. And that's where we go in with shavers and little arthroscopic tools to clean out the tear. Basically, I relate it to basically taking off a hangnail. So we remove the torn portion of the tissue and leave healthy, clean tissue that won't be irritating, won't be a pain generator in the knee. And this is highly successful, can lead to relatively swift recoveries, which we'll talk about, and can be a great option for folks that just aren't doing as well with the conservative options and need to get back to their activity or sports relatively quickly. And then sometimes these tears do have cysts associated with them, so you can actually get some swelling or joint fluid that pushes out of these tears, and those need to be treated surgically as well. So we look for those as well. It's easy to see on an MRI. A lot of the questions I get are about Baker cysts, which are a little different and are usually unrelated to an actual meniscus tear. Baker cysts are a swelling in the back of the knee. I see them very commonly. They're more associated with arthritis, so wear and tear in the knee. And this is when joint fluid actually pushes out of the back capsule and creates kind of a pocket of fluid. And it's not actually a cyst, so to speak. It's more of an expansion of the actual knee joint that causes some swelling in the back of the knee. They're very benign. They're harmless, but can cause a little bit of achiness in the back of the knee at times. I usually don't recommend doing anything about them surgically or draining them. A lot of them can resolve with time. So then, talking about arthroscopy for degenerative tears, we talked about those acute tears, those all of a sudden one-time injury tears. A lot of what we see are these degenerative tears, so wear and tear type meniscus tears. And it is relatively debatable what we do about these. So there was a study out of the Houston VA hospital about 20 years ago, and it looked at a few hundred participants, and sorry, I'll jump back here, went over 3 different types of surgery. One was just making incisions on the knee, and these participants knew that they would be part of the study, so they opted to be part of it if they got this, and there are 3 options. There was just making incisions on the knee, and what the surgeons did while the patient was asleep was just basically clang instruments and drop some water on the floor, and that was it. And then they sewed the incisions up, did nothing inside the knee. And then the second type of surgery was irrigation, going in there and basically just running water through the knee, and that was it. And then the third category, third group of patients got actual oral surgery, what we do, the cleaning out the meniscus, shaving cartilage, and seeing who did better. And remember, this is in patients who have wear and tear degenerative tears, along with a little bit of arthritis. And they followed people for 2 years and looked at their knee pain scores kind of on a 0 to 100 scale. And their results, at least, showed that there was no real difference in all three groups, whether they just got incisions, whether they ran water through the knee, or they shaved the cartilage. So in the setting of arthritis, this has been the new school of thought since this study, that just going in and cleaning out arthritis, wear and tear of cartilage, is not that helpful. Although, one thing to note is everybody did get better. Nobody was harmed, and no group was harmed by doing this, but everybody got better to some extent. Just nobody, the surgery itself didn't cause any significant improvement over the others. So it's important to watch out for actual arthritis. Meniscus tears alone do get significantly better with surgery, because it actually removes the damaged tissue and removes the pain generator. But when there's underlying arthritis, it's important to know that you can't remove that. There's no way of spackling new cartilage in. There's no way of actually increasing the cushion. So it's not very helpful to go in there and just clean it out, so to speak. So going over recovery, repair takes a lot longer. I add about 6 weeks to 8 weeks to the recovery period. There's weight bearing, so you can't put weight on it. So we have those weight bearing precautions using crutches for about 6 weeks. That's when we repair the meniscus. And then we work on getting quadricep strength back, working on full range of motion over that 6 weeks to 2.5 month period. And then usually this is under the guidance of a physical therapist, and then return to sports are about 3 months later for repair. When we just do the clean out, the debridement, it's much faster. I usually say the first 1 week is the most swelling and usually the most pain, and then by about 2 weeks, people are getting their motion back or walking without any crutches. You don't really need even crutches. People can walk right out of the recovery area, actually. I don't have any restrictions for patients after this type of surgery. So that's nice. The downtime is very limited. And most people I will let get back to running at 5 to 6 weeks if they want. So usually it's about a little over a month off. And once strength and range of motion have returned, people are usually doing really well. Swelling doesn't last a whole lot longer than a week in general. So a relatively swift recovery period when it comes to surgery, and very, very helpful. Usually once we clean out that torn meniscus, that pain generator is gone and people feel much better. So that's the nice part of that. And then, although it's a little off topic, I wanted to include it because it's very much talked about, and we see a lot of patients who are requesting this today just because arthritis is so prevalent, but talking about knee replacements. And in the setting, it's kind of a continuum that folks with degenerative meniscus tears, wear and tear type tears, usually have some element of wear of their cartilage, often. And as the meniscus provides less and less cushion over time, then the cartilage gets less support, and it can lead to arthritis, so-called osteoarthritis. And the last final option for this is a knee replacement. And they work very well. It's definitely the answer when there is no healthy tissue left in a part of the knee and it's causing significant pain, limiting folks' activity. They're unable to walk or participate in the activities they enjoy. So what is a knee replacement? Knee replacement is basically a resurfacing. So it's not just taking out the whole knee and putting a new one in. It's basically placing a metal cap on either ends of the bones, on the femur and on the tibia, and then a polymer, diminished friction surface that helps allow those metal implants to glide past each other. So that polymer is important for that decreasing friction. And then there's a polymer that goes on the back of the kneecap. So it's those four components, the metal on the ends of the bones and then the polymer in between. And a lot of times they're cemented in, but they can be pressed right onto the bone and the bone can actually grow into them. And one question I get is how long they last. These days, because that polymer is very, very durable, it's in the order of decades and decades. We haven't even had the polymer around long enough to actually say how long it lasts, but we're thinking over 20 years, maybe 30 years or so. So that's a big improvement since about the year 2000. And then the actual surgery, this is not minimally invasive. It's actually takes a front of the knee incision and guides are used, whether it's, you maybe have heard of robotic surgery, but there's some type of guide, whether it's using a CT scan through the robot or whether it's actually guides that are placed on the knee. You can place the implants through specific bone cuts that allow us to do that resurfacing. And it's become highly sophisticated and we can match these implants to each patient very, very well. And people ask me what actually has to get removed, and both the meniscus pads are removed for the surgery and usually the ACL, but the back ligament, that PCL in the knee usually gets maintained. So I mentioned this just kind of for completion's sake and get a lot of questions on it. So let me see here. So some of the main, I'll start with some of your questions. I have a question here about what kind of other conservative options we can use. So I have a question about hyaluronic acid versus cortisone, especially in the setting of some bruising that the patient sustained after meniscus tear. And yeah, it's difficult to say. Usually after an acute injury, cortisone isn't very wise. You want your body to have some element of healing. So if there's any issue of an acute injury, something that happened all of a sudden, I generally don't recommend cortisone. Cortisone is much better for the chronic long-term inflammation. Sometimes HA, hyaluronic acid, can be used to decrease the inflammation. And we do believe that it's a lot less harsh on the surrounding structures and won't decrease the actual healing response in the knee. So definitely an option. And then I have another question here. With knee replacement, what is the period of time for recovery? Always a good question, and it varies quite a bit, but there's kind of some general checkpoints that I say. Usually the first 2 weeks are the toughest. That's when the most swelling and pain exists, and that's just your body getting used to just the actual surgery. I mean, it is a relatively large surgery. And then working from about 2 weeks to 6 weeks, people get the range of motion back slowly. The knee does get a bit stiff, and there's still a bit of swelling, and that swelling can last up to 3 months. And then usually where you start to see the real improvement is from about 6 weeks to 3 months, and that's when people get the range of motion back and they're feeling more active, aren't using any cane or walker, and can start to travel again in about 3 months. And then the improvement starts to level off at about 6 months. That's when people start to kind of see what the new normal is and start to feel really better, think about their knee a lot less. So I would say it's definitely a 4 to 6 month investment of time. It's definitely going to make an impact, but then it's a great investment for a lot of patients in their future. Some common questions I wanted to go over is, why can't you replace the meniscus? It's been tried a lot. People have done everything from cadaver grafts to artificial grafts, and it's really, really challenging to recreate that support and durability that our own meniscus pads have. And any of the replacements I've seen, they help some with pain, but they don't actually decrease the rate of degeneration of the knee necessarily, or necessarily the stability. And it's very hard to get them to heal, just for the same reason that a lot of these injuries are. There's just not good blood flow. So we have not come up with a good alternative to our meniscus. And then a lot of folks ask, why won't my tear heal? And that kind of goes back to the same issue, is that blood supply. It's all about the blood supply. So that's what we look at at the time of surgery and with the MRI, to see how close that meniscus tear is to the outside of the knee where the blood flow is coming from, and that lends itself to a good repair. And then a common question I get is, if I have a tear, do I have to have surgery? And the short answer is no. That you can live with a meniscus tear. They can be aggravating and irritating, but overall they can improve a lot with conservative measures, with anti-inflammatory treatment, injections, and therapy. And sometimes meniscus tears, although they can be acute, they can improve with time. The inflammation will go down. Sometimes those tears can kind of fall back into the recesses of the knee and be less irritating. So not every meniscus tear actually has to have surgery, and that's why it's good to watch it for some time, not just to rush into surgery, kind of see how it goes. And it becomes pretty clear whether this is something over, say a course of anywhere from 6 weeks to 3 months, to see whether it's something that's going to be getting better with time. And then, will my knee wear out faster if you remove part of the meniscus? It's not really well known. What we do know is that if we take out meniscus, it's meniscus that wasn't helping already. And so torn meniscus is not providing any support of the knee. It's not providing any cushion. It's just, it's not useful. So taking that out is not going to actually lead to more degeneration. The damage has been done, so to speak. So a meniscus tear can lead to your knee wearing out a little bit faster, and it's all relative to the significance and the type of tear. So a lot of the minor tears are actually relatively inconsequential in the long run, as long as the cartilage of the knee is intact. So it's kind of a multifaceted answer to the question. It's a complex problem, but just going back out and removing with an arthroscopy that damaged meniscus does not necessarily lead you to more wear and tear in the knee. And then lastly, how long until you feel better? Just to kind of reiterate, it's relatively quick. Folks don't need crutches more than a few days after a debridement, so that clean out surgery, and can get walking really quickly and back to jogging and that level of activity at about 6 weeks or so, and return to work is relatively quick. So a good option for these tears.